Welcome everyone. You're listening to the ICCA India podcast. Through the podcast series, we hope to bring out multidisciplinary dialogues by discussing the intersections of economics, policy, and cancer.
Welcome to the ICCA India podcast. As many of you know, this is part of a series where we're opening up a conversation on cancer diagnosis, treatment, care, but really from the perspective of many of us in the ICCA India podcast. We are part of a project which is 4 countries. We're really interested in asking questions about the industrial organization of cancer, the cancer system, the way we think about diagnosis and treatment, the economics and policy behind it. So if you are following along, today we are absolutely delighted to have Dr. Pramesh, who's the director of the very well-known Tata Memorial Cancer Hospital. And we will not go extensively into his bio here. The idea really is to keep this engaged for all of you to follow along. And Dr. Pramesh will have a chance to introduce himself, and we'll get right into it. So, Dr. Pramesh, thank you very much for joining us. This is part, as you know, of the ICCA project, and it's a chance to open up the conversation.
Thank you. Thank you very much, Smita, and thank you for this opportunity to be part of this series of podcasts. So very briefly to introduce myself, my name is Pramesh. I'm clinically a thoracic cancer surgeon, predominantly treating cancers of the lung and the esophagus. But more lately, my role has been as the director of the Tata Memorial Hospital, which is the largest and the oldest cancer center in India, treating over 70,000 new patients with cancer annually. I also coordinate a network of cancer centers in India called the National Cancer Grid, which currently is at over 250 member centers, which with the mandate of having uniform standards of care across the country to create human resource to tackle the growing burden of cancer and to serve as a ready platform for collaborative multicentric cancer research. So I'll stop with that, and I'm happy to discuss further on many of these aspects as the podcast goes on.
Now, you mentioned a large body of patients who come in the door every year, and some of them are new, some of them are older continuing patients. What is the relative fraction or the relative number of cases that you're seeing new versus those that are routine treatment? Routine may be the wrong word to use, but you get my point.
Sure. So as you know, cancer is not just a one-off encounter with the hospital. So with the result that a large number of our patients actually keep coming back for follow-up even after the cancer treatment has been completed. And this is important because many of these might recur, and if you pick up the recurrence early, there is potentially still the possibility of meaningful treatment. So on an average, what we see, and I'm talking pre-COVID times, is about 70,000 new patients annually and over 600,000 footfalls overall every year. So approximately 10% of the overall footfalls are new patients getting registered with us and getting their cancer worked up and the treatment going on, whereas the rest would be patients who are on regular follow-up for their earlier cancer.
And from in our prior discussions as well, we've kind of run the gamut of different kinds of cancers, of which, of course, the kinds of treatments you provide are very wide, very varied, and you also have a lot of specialists. So for someone who's listening in to this podcast who doesn't really think of cancer as many different types of diseases, could you say a little bit about this particular challenge, the classification of cancer?
Right. You're absolutely spot on. So cancer is not just one disease. It's a conglomeration of multiple subtypes. And the importance of this is that while some cancers are fairly innocuous, though this seems completely counterintuitive to someone who might have heard the dreaded word of cancer being equated with almost the end of life, there are cancers which have upwards of a 95% long-term survival, and there are cancers which have less than a 5% long-term survival. So it's a spectrum of disease rather than one disease by itself. So on one hand, you have cancers like thyroid cancer, prostate cancer, hematolymphoid cancers. These are the blood cancers, leukemias and lymphomas, which, if treated appropriately, have an extremely good prognosis. So it's almost like you probably have a better chance of surviving these types of cancers than you have of other diseases like, let's say, for example, pulmonary fibrosis. On the other hand, you have fairly lethal cancers. These are typically pancreatic cancers, lung cancers, and liver cancers, where the problem is that most patients present to us at a very advanced stage of the disease, with the result that the potential for cure is extremely limited in these cases. And this was the other end of the spectrum, which I mentioned, which is a long-term survival of less than 5%. So the key message here is that not all cancers are the same, and the kind of nihilism that is associated with a cancer diagnosis is not always appropriate. As I mentioned, there are cancers which have upwards of a 95% survival. And even in the cancers that I mentioned, which were more lethal, like pancreatic and lung cancer, if you detect them early, so for example, the long-term survival with stage 1 lung cancer is in the range of 70 to 80%. So even within the same disease, which is lung cancer, you have stage-dependent survival, as you might assume. But even within the disease, there are multiple subtypes of lung cancer, some of which have a better outcome than others. So it's a mistake to lump them all together in one basket, but important to recognize the fact that at the very least, we need to get an accurate diagnosis and thereby make some prognostic decisions which might help with our treatment decisions as well.
Now, one of the things, as you know, with the ICCA project is we're trying to think of this through some of the dynamics of the firms involved, trying to think through the industrial organization of cancer care, and also trying to understand some of the ways in which the economics could be resolved, renewed, revitalized. And you and many of your colleagues, of course, have been dealing with both a prevention question as well as the people coming in the door who all need your full attention. And you have to attend to people who may conceivably step in through the door tomorrow. So how do you think of this problem? Is this, people might address this as a kind of a fairly complex stock and flow problem, but you could think of it in other ways. What is your mental model of how you prevent people from getting cancer, given cancers are so complex and of different types?
No, that's a great question, and I'm afraid there's not a simple, straightforward answer to this, as you might imagine. It is fairly complex, and while it's always nice to think of cancer as a better preventable disease rather than a curable disease, I would agree to some extent, primarily because the incidence of cancers are very varied. So, for example, if you look at India, the annual incidence of cancer as a proportion of the population is fairly low. So again, this is something that's counterintuitive, seeing that cancer centers are overflooded, but this is more a factor of the large population that we serve and the fact that we don't have enough cancer centers rather than a reflection of the cancer incidence itself. So just to give you an idea of what the numbers we are talking about are, in India, in urban India, we have a cancer incidence in the range of 100 to 110 per 100,000. Whereas in rural India, it almost halves. It's 50 to 60 per 100,000. Contrast this with countries like Australia, which have over 500 per 100,000, and the United States, where it's over 350 per 100,000. And we're clearly dealing with multiple factors which contribute towards this low incidence. People might argue that part of this is underreporting, and I do agree that there might be some level of underreporting in these numbers, but we've had population-based cancer registries in several parts of India for several years with house-to-house survey, and the underdiagnosis is unlikely to contribute much to this discrepancy. So there is something in our lifestyles which seems to protect us from cancers much better than what is happening in the West. This is also a reflection of the fact that in the West, there is much more screening than we do in India. And though screening is great for some cancers, it also does have its flip side in the sense that it picks up a lot of innocuous, non-lethal cancers, and you actually end up over-treating them. And I don't think that's a path that we would want India to go. So that's one aspect of the incidence issue. The second bit is what you said about prevention being better than cure. And I do agree to a large extent, but I think we underestimate the logistics of prevention. So it's very easy to say that 40% of cancers are tobacco related and another 20% are related to physical inactivity and infections. But it's easier said than done to get people to stop tobacco. So in the best of centers, when we have tobacco cessation programs, the long-term cessation of tobacco use is in the range of a single digit percentage. We are not even touching 10% more than 1 year of tobacco cessation. So it's easier said than done. And though legislation to a large extent has helped, especially in countries like the US and Western Europe, where increasing taxes on tobacco products and ensuring that in public spaces smoking is prohibited has brought down tobacco use to a large extent. This is much more difficult to implement in India, where it's a largely unregulated tobacco industry. So prevention, while ideal, is not an easy nut to crack. And at the same time, because of the large population that we have, we see 1.3 million new patients with cancer annually. So where do these people go? It's not going to vanish even if you have the ideal preventive scenario. So I think you need to balance these two between this thing, at least in the foreseeable future. I don't see cancer disappearing anytime in the near future. So I think it's a parallel activity rather than competing with each other, fully realizing that prevention is not as easy as some people make it out to be.
So, but you've raised an important point here. So one, on the screening side, obviously if the screening levels are upped, or at least there's a way to do it where your error margins aren't too high, you would imagine that at least you're getting more people into the scope of scrutiny, if not firm diagnosis. So what is the equipment requirement for this kind of, you have been not only dealing with the very exciting new initiatives of the National Cancer Grid, you've also been writing prolifically on choosing wisely and the reason to think about new national, more customized institutional guidelines. So talk me through both the need for a national strategy, something more customized to our populations, even subnational populations, and then the separate question of minimum stocking, use, training of equipment, because obviously we are a little biased in that direction. We're trying to think through what it really means for the economy to have priorities in that segment.
Coming to screening, it's a great tool in certain cancers. But what we must understand is that for screening to be a population-based strategy, it needs to fulfill certain criteria, which we think are pretty basic as far as identifying diseases for screening go. Cancer is a great model for that because most patients come to us at an advanced stage, and we would love to get patients at an earlier stage. But nevertheless, we need to understand that first, it needs to be a major public health problem. So while there are certain cancers which have a very high incidence in the West, and therefore there's a huge push towards screening for these cancers, like, for example, prostate cancer, it's a much smaller problem in India. And therefore, chasing after these small subsets of population and trying to diagnose them early really doesn't make sense. But something which is even more important is the fact that there needs to be evidence to support the screening method that's being used in a robust manner, not just downstaging. Downstaging by itself is not adequate to demonstrate evidence of efficacy of a screening tool. There actually has to be a reduction in mortality. And when you look at these two filters, you find that very few screening tools have actually met these filters. So, for example, you have mammography in women over the age of 50, and certain tools for cervical cancer screening in the form of pap smears and HPV DNA. And in probably very few other cancers do we have reliable methods of screening. So, for example, serum PSA or prostate-specific antigen in prostate cancer has never really been demonstrated to reduce mortality. In fact, there are some studies which show that there is a small non-significant trend towards an increased harm being created by prostate cancer screening. So that's a path we should definitely not go through. Coming back to breast, cervical, and oral cancers, which are major public health problems in India, we do have the possibility of screening them with the tools that are done in the West, which is mammography and HPV DNA or pap smears. But there are enough studies in India that have been shown that these are not feasible when you roll it out in a population level. So even for something which is not very high tech like the pap smear, you do need cytologists, technicians to be able to interpret these smears reliably. And there's an ICMR study done a few years back which showed that even if you were to multiply the number of cytologists and technicians manyfold, you would still be able to screen only 1/4 of India's women in that age group, and that too once in their lifetimes, which is actually not a very feasible option. Which is the reason why we have actually completed very recently 2 very large community-based cluster randomized trials on breast cancer screening as well as cervical cancer screening using low-tech, low-cost tools. So for cervical cancer, we use visual inspection with acetic acid. We did a study in 150,000 women in Mumbai, where we demonstrated a 30% reduction in mortality due to cervical cancer by using a very simple tool. And the proof of the fact that this is a feasible intervention to scale up is the fact that several states have adopted VIA as the screening method of tool, and so is the national screening policy linked to VIA as a method rather than HPV or pap smear. Similarly, more recently, we came out with the long-term results of the breast cancer screening trial in the same group of women, which again demonstrated a very simple intervention, which is clinical breast examination by trained health workers. Nothing fancy, no mammography, no MRI, no thermography, simple clinical breast examination by trained health workers, which again demonstrated a 30% reduction in breast cancer mortality in the above 50 age group. So if you have to look at a feasible, scalable solution to India, I'm afraid we are not looking at very high tech. We are looking at very simple technology being implemented by healthcare workers who've just been trained for a few months on how to do the test and how to interpret those results. And I think this is the one that's likely to be scalable in countries like India.
So one point that you've raised, which I sort of want to kind of come back to, is that on the one hand, the traditional division between what is preventative and what is a patient walking in the door is usually defined by the kind of the screening line, if you like, on a life cycle of a patient. But if that screening line, without too much certainty, is either getting blurred over time by the instruments being used or the non-availability of instruments, and therefore screening doesn't happen, you're really suggesting that perhaps much, not earlier stage screening, but much earlier stage education and training becomes essential as a part of early screening. It sounds a little bit like the tech-driven screening paradigm that we have had perhaps really fails us in many respects.
So I would agree to some extent in the sense that the traditional tech-based solutions seem to be failing us when you look at a country like India. Having said that, I'm still a big fan of technology. I still have faith in the upcoming technology to try and see whether there are other solutions beyond what we've already discussed, beyond the HPV DNAs, beyond the mammographies, and look at other point of care devices, for example, something which can use telehealth better. So there are plenty of advances that are happening in technology now, and I wouldn't think that it is impossible for this problem to be solved using technology. But what we currently have is the fact that none of those traditional existing technologies are serving us very well in a population as large as India with the health resources as they exist in India. So again, you brought in another point about this line between screening and actual patients walking into your door with symptoms. I think there's another blurred line in between these two extremes, which is early detection. And I want to differentiate or discriminate early detection of symptomatic individuals from screening. In screening, what you're actually doing is pick up someone who's completely asymptomatic, run a few tests on him or her, and come up with a diagnosis. So this is a population which is actually asymptomatic. But in India, I suspect that there's this fairly large proportion of individuals who have symptoms of cancer, who might either not have visited a doctor or might have visited their primary care physician but not been diagnosed with cancer. So to me, education and awareness at both these levels, at a population level, warning them about early signs of cancer, and at a physician or a primary care physician level, having a lower threshold to investigate patients who have symptoms of cancer, are things that we don't talk much about. But I think these are extremely important aspects to think about if we are actually trying to shift the stage from an advanced stage to an earlier stage.
So there has been, of course, a discussion about perhaps too much vertical specialization in doctors, and maybe a loss of some of this early stage, even front end meeting with whether it's GPs or others, which of course is a training issue as well. I mean, it works both ways. But just to come back to the question of tech, at least being agnostic about tech, and trying to find the right system that would work for the right problem. In the Indian case, it does look like the Choosing Wisely initiative was one way into this, right? So based on clinical evidence, to try and understand what it is that is at the bare minimum needed. So could you talk us through that, and then maybe let's just segue into the National Cancer Grid. In your mind, how are these two things related? Choosing Wisely, National Cancer Grid, and where is this question of priority setting in terms of the problem frame?
Right. So these are extremely closely linked, and the Choosing Wisely initiative actually stemmed from some of the discussions we had during one of our annual meetings of the National Cancer Grid on health technology assessment. So we were very keen that the scant money that we have on healthcare expenditure is used better than what it currently is. And again, surprisingly, overuse of interventions is as big a problem as underuse in a country like India. And when you know that the pot of money towards healthcare is limited, you want to make sure that it's used well. But what we realized very rapidly was that health technology assessment is not a quick and dirty way of getting value-based care. So we started taking baby steps, and that was the first initiative that we took, which was Choosing Wisely. So Choosing Wisely, as many of you might be aware, is an initiative which started from the American Board of Internal Medicine, which recognized the fact that what I just mentioned about overuse being as big a problem as underuse in several areas. And I guess in countries like the United States, it's a much, much bigger problem than it is in India. But nevertheless, it's a problem that transcends geographical boundaries. So what they went ahead and started doing was to try to identify those practices which were common in the healthcare scenario which was being studied, and either had low value, no evidence, or were actually harmful for patients when it was implemented. And that's a similar approach that we took. And we identified for cancer a set of 10 practices in India which were commonly performed, had either low value or could actually be harmful. But the difference between our effort and efforts in the West has been the fact that we've also taken value into the consideration. So Choosing Wisely International, which is primarily based out of the US and Canada, prides itself on not getting cost as a reason for choosing wisely. So they emphasize that it's the evidence and the harm that you need to emphasize on, and they've strictly stayed away from the cost aspect of it. Whereas in countries like India, I think you cannot get away from the fact that cost should be an integral part of decisions like this, and therefore this is slightly different from the other Choosing Wisely efforts. And when we talk of cost, it's not just the cost of the intervention itself, but also the opportunity cost that is associated with it. So I'll give you an example with one or two of the Choosing Wisely recommendations that we made as part of the Choosing Wisely India recommendations for cancer, which is distinct from what Choosing Wisely US or Canada did. One of them was regarding the overuse of PET CT scans in cancer diagnosis. So a PET CT scan is something which picks up spread of cancers in areas where you typically don't expect cancers to spread. So if you have a CT scan showing a local disease in the lung, for example, in the case of lung cancer, a PET CT scan might pick up spread in areas which are not typically imaged using a CT scan of the chest. So this is a useful investigation, especially when it comes to early disease, but very often it is used merely as a way of monitoring response to treatment in very advanced cancers. So with the result that PET scans are not easy to come by, and when you clog the system with a lot of PET scans which are done for unnecessary indications, you're actually denying patients with early cancer the opportunity to get a PET scan themselves. So these are the kind of opportunity costs I was talking about. And another example is the rampant use of intensive care at end-of-life situations. You have patients with terminal, very advanced cancers, gone through 3 or 4 lines of chemotherapy. And when they are faced with a typical end-of-life situation, we don't have as much shared decision-making with patients and families as we should, with the result that these patients get bundled into intensive care units, get a lot of very high-end investigations and treatment being done. They get put on a ventilator, which is not actually helping either the patient, the family, or the healthcare system. And these are the kind of costs that we are talking about when it comes to choosing wisely. So I think it's important for us as clinicians, as healthcare providers, and actually even as the general public, to recognize the fact that interventions are not always helpful. And we need to recognize and take some decisions on what is useful and be able to choose which interventions are likely to be useful and which are not. And that's exactly what we've suggested with the Choosing Wisely Cancer in India.
And for the National Cancer Grid, which of course is scaling this up in quite an extraordinary way, tell us a little bit about that. Something you think would allow us to, a general audience in particular, to understand that they are part of a quite dramatic shift underway in India.
Right. So we did a kind of a heat map of patients, close to 75,000 patients who visited us at the Tata Memorial Hospital over a 6-month period, just to get an idea of where they were located from. So we geotagged them. And the kind of figures we got were fairly disturbing. Just 14% of patients came from the city of Mumbai, where we are located. And just 40% of patients came from the state of Maharashtra, where we are located again. With the other side of the coin here is that 60% of our patients come from distances which are very far, and a substantial part of them come from states like Jharkhand, UP, Bihar, West Bengal, and an extraordinarily large number proportionally from the northeast of India. And just to give you context, the time it takes for someone to travel from, let's say Naharlagun in Arunachal Pradesh to Mumbai, even if you were to fly, is anywhere from 1 to 2 days. And that's a huge challenge. And again, the challenges of living in a city like Mumbai, trying to access high quality care. So the government of India came up through the Department of Atomic Energy, came up with two solutions of looking at this problem. The first was, they asked us at the Tata Memorial Center to set up newer cancer centers in those areas which had the maximum need. And we have expanded substantially in the last few years. Out of Mumbai, we've now set up centers in Varanasi, Visakhapatnam, Chandigarh, and in Guwahati. But you might well realize that in a country the size of India, having these islands of excellence by themselves is woefully inadequate. So what seemed to be low-lying fruit as far as solutions were concerned was to try and have uniform standards of care across the existing cancer centers in the country. So when we started this in 2012, we invited the 29 regional cancer centers to participate in an effort to try and reach consensus on uniform standards of care. So that's how the entire birth of the National Cancer Grid happened. And out of those 29, 17 of those centers came in for our first meeting in August of 2012. And we agreed on certain basic principles, which still stand as the pillars on which the National Cancer Grid was founded. And these include having uniform standards of care. The second being an effort to develop human resource to treat cancer, the increasing burden of cancer. And the third, which is to have a ready-made platform for collaborative cancer research, and none of which existed prior to this initiative. So over the years, over the last 9 years, we have grown into a very large network. We are currently at over 250 cancer centers, research institutions. We've expanded the scope to include patient representatives who we feel should be an integral part of all decisions taken on cancer care in the country. We also have some charitable organizations and professional societies buying into our effort. So between these member centers, over 750,000 new patients with cancer are treated annually, which is approximately 60% of all of India's cancer burden. So initiatives within the National Cancer Grid have a serious impact, provided they are robust and they are effective in ensuring that we work towards our stated mandate.
So for the NCG, is the imagination eventually that these regional cancer centers trained part of the guidelines that exist of the NCG, the kind of expertise, you have your tumor boards, you have other kinds of training and expertise available. Is the imagination that the lay cancer patient walking in will find a different ecosystem at the district level? We're still talking state capitals and maybe a few others. What's the imagination and what timeline are we looking at?
Yeah, so as you might imagine, a change of this nature cannot happen overnight, and we are very realistic about the magnitude of change as well as the duration of time it will take for us to reach this ideal utopian goal of having exactly the same standards of care regardless of where you come from. And I don't think we are ever going to reach 100% realization of this utopian dream. We will reach close to 80 to 90%, and that's something which will be remarkably different from what is currently the situation. So there are some challenges which face us, and many of the efforts that the National Cancer Grid has taken has been towards a few areas which hopefully in the long run will work towards equal or equitable care. The first is on uniform standards through guidelines. More recently, we've come up with resource stratified guidelines, which divide these into essential, which we feel are the bare minimum that a cancer center should have, without which they should be referring patients to the next higher center, and optimal, where you probably have the ideal situation where there is expertise as well as experience available, the infrastructure available to treat even some of the more complex cancers. And finally, the optional, where we don't really look at cost. Whereas with the essential and the optimal, we ensure that the benefit or the outcome that's being provided by this intervention is commensurate to the expenditure that's involved there. Whereas if many of the breakthroughs or so-called breakthroughs that we've had in cancer in the last couple of decades, the marginal benefits that they accrue are not really worth the expenditure that's spent on them. So there are fascinating studies on what's the expenditure per quality of life year adjusted is achieved. And in countries like the US, they range anywhere from $250,000 to $1.25 million per quali reach. So this is a country which has a much higher GDP than India, even adjusting for purchasing power. And we realize that those kind of standards are practically not feasible for the vast majority of India's population. So we need to be value-based as far as the guidelines are concerned. We have a very heavy emphasis on quality. Often we focus only on the cost of care without really thinking about the quality. And we realize that with very systematic interventions, we can bring up the quality of care without really investing too much. And some of our efforts in this area are on having uniform standards of pathology reporting, for example. Mm-hmm. So many of the top cancer centers in the world go through something called a College of American Pathologists accreditation system. And most of them hate this process because it's an extremely labor-intensive, time-consuming, and very, very expensive way of getting your lab accredited. So what we've done in the Cancer Grid is to have a leaner, meaner version of CAP, which we offer completely free of cost to our member centers. So we've automatically built in that level of quality into the equation. The final point I want to talk about as far as quality is concerned is something that happened serendipitously when we developed our resource stratified guidelines. So we had invited the then Deputy CEO of the National Health Authority, Dr. Dinesh Arora, for one of our National Cancer Grid meetings when we launched the resource stratified guidelines. And the moment he heard about this, he was fascinated by this, and we got complete buy-in from the NHA on linking these guidelines to reimbursement under the Ayushman Bharat. And Ayushman Bharat is the largest government-funded insurance scheme in the world. And though this was not something that we had plotted or planned, it became automatically a way of ensuring that there is quality of care provided to 40% of India's population who are covered under the scheme. So these are the kind of unrelated interventions which have come in to ensure that, or working towards our ultimate goal of making sure that patients don't have to travel long distances, reach quality care. And the final point, again, is what you mentioned earlier about the virtual tumor boards and several of our education initiatives, which again go towards ensuring that regardless of which cancer center you belong to, the staff of that cancer center is exposed to the best practices in some of the top cancer centers, and thereby, again, bringing in this level of quality and pushing centers and professionals involved in treating cancer a step higher than they would otherwise have been.
And one question really on the relationship between family medicine, GPs, and the relationship to the system. Where is it that although our study is not directly focused on patients, it really does matter to sort of the industrial organization of cancer care what that relationship looks like and how much further you push back or forward the line between early screening, the kind of relationship between diagnosis and treatment. So what's the hope here, and what would that look like at a much more decentralized level?
Right. Again, a very important point. And this is not a place where we've done very, very well within the National Cancer Grid. So we have a terrific network of cancer centers. But the missing link here is exactly what you mentioned. It's about the general practitioners. It's about the primary care physicians, the Ayush practitioners who are often the first point of care for several patients. So we've not really done very well. We've not penetrated that segment very well. We're looking at solving this by two efforts. The first is research towards identifying what are the barriers to early diagnosis and for early access to specialized cancer care. And we are currently in the process of doing a pilot in 3 different locations in India, very varied healthcare systems in UP, Mumbai, and in Kerala, which, as you might understand, are completely different healthcare systems, trying to identify what the barriers to care are, and what's the reasons for the delay in accessing care. The second effort that we've taken is, and we've taken some initiatives there, is to decentralize this even further. So we want to go down from the hospitals treating cancer right down to the grassroots practitioner. And we are creating state chapters of the National Cancer Grid. So we do realize that a centralized way of functioning of the National Cancer Grid may not always be able to reach these grassroots level. So we are empowering states or member centers of the National Cancer Grid in individual states to create state chapters so that then they go the last mile as far as reaching out to the primary care physicians is concerned, even to the general public. We've had several efforts at creating awareness both amongst the practitioners as well as the general public, but more importantly, getting ownership from general practitioners into the state chapters so that they feel equally invested in creating a very flat, non-hierarchical structure where they feel confident about contributing towards this larger cause of early diagnosis of symptomatic patients.
And one really last question. When you think about not just equipment, but kind of the entire dynamic of the health industry as we have it in India today, we have a sort of quite a scattershot approach because these are firms that are coming into a system where they are more or less profitable segments, or even if their sole function was not to come in for profits, they certainly have to deal with a great deal of uncertainty to understand where the changing compass is for quality standards, certification, priority spending, reimbursements, all of the rest of it. Is there as you know, for the ICCA project, we are really focused on some of these quite difficult multidisciplinary conversations. We're all trained differently. We might have similar goals in terms of wanting to see a more equitable or more efficient option that could come out. What is the relationship between the different aspects of the health industry? Because at one level, hospitals are also part of the kind of the industrial organization of cancer screening, diagnosis, and treatment, and rehabilitation. So how do you think about the NCG and the health industry broadly?
No, I'm glad you brought this question because this is the elephant in the room. We live in a country where the overall expenditure on healthcare is under 4%. We live in a country where 3/4 of healthcare expenditure is out of pocket, which means that we're talking of a 1.5% investment, a GDP investment in public healthcare, which is, in my view, woefully inadequate. So for starters, I think we need to increase this. There's no way of being able to offer high quality healthcare to our citizens if our public healthcare expenditure is under 1.5%. This is something that I think governments need to address very urgently. The second aspect is, given the fact that these numbers aren't changing very much over years, and the fact that even if you were to double this, it would just come up to 3% of public healthcare expenditure, which again, in my view, is inadequate. But even if we were to double this, that's the kind of numbers that we're looking at. We need to make sure that this money is well spent. And it's initiatives like Choosing Wisely. And I don't for a moment think that Choosing Wisely Cancer for India is going to make a big dent. We need to get all healthcare areas to start thinking of choosing wisely, ensuring that money is well spent. The next aspect of this is how can we leverage the fact that we are a large population and try and reduce the overall cost? How can we make our healthcare delivery more efficient? And we need to look at a more distributed model of care. So we are being penny wise and pound foolish if we assume that patients can travel from Arunachal Pradesh to Mumbai and access treatment, and we offer treatment at the Tata Memorial free of cost. It's already a lost battle because the patient has spent much more than what they would have spent otherwise locally, just by the travel and the costs of living in a city like Mumbai. So we need to look at this as an overall expenditure and not just at the direct costs of cancer care or the cost of the medicines. But having said that, the cost of medicines and equipment and consumables in healthcare and cancer in particular has been burgeoning beyond sustainable limits. I think even in countries like the US, they're struggling with their healthcare budgets, and the US spends about 19% of their GDP on healthcare. And countries like in Western Europe and the US are still struggling to meet expenditure as far as healthcare is concerned. So what we need to look at is innovative ways of negotiation. So at the National Cancer Grid, we have a system of negotiating as a group. So what we do is to collate demand from member centers within the National Cancer Grid and use the fact that these volumes are exponentially higher than what individual centers would have. We negotiate as a group with industry, and we've been able to demonstrate that this is an extremely efficient way of getting prices down. And for industry, this is a win-win situation, because rather than get into negotiations with 100 centers, they deal with just one center, and the actual distribution happens differently, but the negotiations happen at one point. And what we are able to offer industry is huge volumes. And hopefully the margins that they get with these huge volumes will enable them to reduce their drug prices commensurately. We've not tried this for equipment yet, and it's not been for lack of effort, but we realized that with equipment, it's a tougher nut, because there are subtle variations between different equipment which industry is able to exploit and emphasize to end users that their product is superior to the competitors, and thereby we are not able to drive the volumes adequately to be able to negotiate with equipment manufacturers as well. But that's again not something that's far-fetched. We will look at some of that in the years to come.
So I never want to be between a surgeon and his or her work. So Dr. Pramesh, thank you very much for the time you've spent. We're hoping that this podcast series opens up a set of conversations so that people really understand that not only is change underway, there are priorities. It's not that everything has to change at once, but some changes can be more effective than others. So thank you very much for joining us today.
Thank you very much, Smita. It's been a fascinating conversation, and thank you for having me.
Thank you.
Thank you for listening to the ICCA India podcast. Do follow our social media handles and stay tuned for the next episode.